Hello, everybody. This is Fred Kranz from St. Ange. Today, we're going to be taking the pulse of the healthcare supply chain with Steve Downey from the Cleveland Clinic Foundation, which is very appropriate because for the last 29 years, Cleveland Clinic has been voted the nation's #1 cardiac care health system. So if you're going to have your pulse taken, I guess the clinic is the place to go. Glad to have Steve here. Steve, thanks for coming on and talking with us. We're starting this series to bring some of the real leaders in healthcare supply chain visible to other people who may not be able to, see you and learn some of the problems you have. Hopefully, the things we talk about here can be applicable to other people in their jobs. So I really appreciate the fact that you come on board. I don't know if you know this, but you and I do have some things in common. You went to Lehigh, and I was the supply chain leader at Lehigh Valley Health Network for a year in Allentown. So Allentown and Bethlehem are covered. Easton is left to Larry Holmes, I guess. You came from Vizient. I worked at VHA Performance Consulting. So we've got that in common. And then CCF now owns Timken Mercy Medical Center, which is what it was called when I was a supply chain leader back there in 1983 to 1989, and Meridia Health System, which I also was a supply chain leader in. So surprisingly, we have a few commonalities there. And you live in Chagrin, and I live in Cleveland Heights, the home of the Kelsey brothers. So you can't beat that.
You can't beat any of it. But my wardrobe is not as amazing as yours, Fred.
Have you noticed I'm very conservative today? We're still up in the air about what direction to go with this. We want to have fun with it, but when I'm talking to someone as important as someone from the Cleveland Clinic Foundation, I feel I must dress up. So, so tell us a little bit about yourself, Steve, and then you can do some questions.
Sure. Been around healthcare my whole career. My passion was always around the patients, and I always found the closer I got to patient care, the happier I was. So started at Lehigh as an electrical engineer, really focused on biomed, and went into med device, did engineering and operations, and then onto the commercial side. So really found I liked the sales, marketing, new product development world, and then got into supply chain because I knew what health systems wanted. I'd done a lot of work with surgeons and supply chain, and the more I talked to them, the more I could just translate that to needs. And there was just a lot of complexity in supply chain and a lot of challenge, but a lot of growth. Some great global roles. Did some larger med device, again, all supply chain, and then moved to third-party logistics, which was fascinating to see the health systems and then pharma, med device, all areas I'd been around, but then also CPG, and get a feel for how they handled healthcare. And so folks like Target and Walmart really think differently about supply chain, and to see what healthcare was doing and missing. Like, for example, I was there in the early days when Walmart put in their on time and full penalties, the OTIF. And so bringing that over into healthcare, we spent a lot of time talking about how to measure supply performance and OTIF, and I learned it from the ground up there. Then Vizient, and ran supply chain operations for Vizient, lots of exposure to health systems, and ran outsourced operations and data and buying and supply chain, and then have the pleasure of running the clinic's supply chain and food services. I've been here for almost 3 years.
Well, great. And you're also the CEO of a GPO as well with Ohio Health. Could you tell us a little bit about Accelerate?
Yeah, happy to. So Accelerate's a joint venture. It's with Vizient and Ohio Health. It's really the clinical expertise that the clinic and Ohio Health bring with the performance management GPO side of Vizient. So it's a GPO. It focuses really on physician preference items, PPI, and a committed portfolio. So the clinic and our supply chain has spent a lot of time focusing on commitment and narrowing down our supply base for, let's have a very small amount of vendors for a given product. So we know a lot about how to work with clinicians, how to provide the appropriate level of data and insights about that decision. We said we could help others do this. So been doing it since 2014 and grew to now 31 different members all over the country. Lots of large organizations are members, really with the backbone of clinical decision making. And that's the key around PPI is it's got to be clinical driven. We do it on a service line basis, so you don't have to commit to an entire portfolio, but you can say, I'll commit to the heart vascular team or orthopedics or surgical or such. So that allows you to commit where you're ready to commit and where you feel like you can get into the work here and then grow into other areas. But we know it brings the most savings and actually we think brings the best clinical outcomes because wherever you are, you use the same product. So it's been our pleasure to do it. It's a great program.
Great. How difficult is it to build consensus among clinicians?
Well, it probably depends on the health system's commitment to doing it. And so the clinicians and their interest in the culture, if it has always been do whatever you want, now you're making a big left turn, or if it's generally, they're interested. I find that the physicians are interested. And in conversations I have with physicians, it's, what do you think about choosing? Can we get through all of the decision making here? And it's a very data rational decision, and they're supportive. Now, if you don't have a leg to stand on, you don't take all the time to understand the why, then sure, they'll have questions. They're good questions, right? Physicians are very risk driven. So understanding what does this mean to my patients? Will I have what I need to do my procedure? I need to provide care. Totally get that. You need to, as a supply chain leader, make that available. In our model, the medical directors who support supply chain are available to support the decision. So if somebody wants to know, how did you choose X as your heart vascular line? We can put them in touch with one of the top cardiac surgeons in the world. And they can have that conversation about why we chose. And that really brings the risk question out. They get comfortable with, sure, you understand what's going on in the market. I'm talking to a peer here. That's okay. Very rational conversations.
But that's good. I one time when I was at VHA Performance Consulting made the mistake of using the Cleveland Clinic as an example. This was back in the 90s when there were big savings opportunity in ionic versus non-ionic contrast media.
Okay.
And I was in a New England state. I won't tell you what state, what hospital, but they were using 100% non-ionic contrast media, and the savings was phenomenal. If they just adopted the Cleveland Clinic standard of 75% ionic and 25% non-ionic. And I was in front of a bunch of clinicians, physicians, trying to make the case. And I made the mistake of uttering this sentence. Well, the Cleveland Clinic's standards are 75% ionic and 25% non-ionic. And almost in unison, the physician said, son, we're not the Cleveland Clinic. So you obviously found a better way of going about this than I did.
Well, we also have a great medical panel because it's not just the clinic, and all the members, they put a lead physician on our advisory board. So it's really not just what the clinic says, it's what our advisory board says of all these leading physicians from all these top members. And there's a lot of big hospitals in Ohio Health and a bunch of others. So in the very early days, it was the clinic, but now we're so big with all 31 members that it's 31 different folks who have talked about this. And that's, it's not just the clinic says anymore.
Great. Another direction entirely. I live in Cleveland. We were talking about that when we started. You live in Cleveland. You can't fall down without seeing the Cleveland Clinic logo someplace. You guys have a huge geographical reach. And as I told you earlier, I was once a supply chain leader at Mercy Medical Center in Canton, also at Meridia Health, which is Meridia Hillcrest is still out on Mayfield. you guys, when you acquire new members, are many times picking up some infrastructure that's in bad shape, that needs to have work done. How do you handle the over 100 care sites that you have in Ohio? What kind of a daunting challenge is that for you as a supply chain leader?
Yeah, it's a good question, Fred. And I know lots of supply chain folks have to handle size, scale. You're hitting some key points here. Complexity of working with physicians, geographic scale. You're hitting easy ones right at the beginning here. Um, yeah, so our model of care is that it's the highest level of care we can possibly provide, and every life deserves that level of world-class care. So we touch as much as we can, and we want to grow to where we can provide that. That allows us to do folks like what we do in Cleveland, where you have main campus and all of the operations around it, where you have all sorts of infrastructure around it. And it it provides the ability to have geographic center, and we can have a distribution center in Solon, for example, and cover Northeast Ohio generally. But it doesn't cover Florida locations, right? We have 5 locations, Southeast Florida, 1,000 beds down there, spot in Nevada, right? And so you're not covering it from one distribution. We have Abu Dhabi. We have a 360 bed hospital in Abu Dhabi. We have our 180 bed hospital in London, right? So you have broad locations. Our commitment is that those will operate at the same level. So you will get the same care that you get in Cleveland, that you get in Florida, London, Abu Dhabi. We have an institute structure, and the institute structure means we have an institute leader who is working through standard of care. Let's say in heart care, there's a single leader who leads all the ways we're going to do heart care, making sure we are consistent everywhere we are. That's the care standards, the data, the outcome information, the procedures, daily huddles, all that sort of stuff, the practices, they all need to be the same. We have a very system approach to all of that. That starts at the top. That starts with folks saying, we will operate the same. It's not go do whatever you want wherever you are, provide care as you need to wherever you are. It's we will provide the Cleveland Clinic standard of care. So then I sense your next question. How does that apply to the supply chain side? So we try to keep the systems as common as possible. We have everybody on a cloud ERP, same data sets, everything goes into one place. The teams report in centrally where we can. Some of our locations I can't, but generally report in. But the practices are the same. How we handle bill onlys. There's a procedure how we handle bill onlys. Receiving, cycle counting, inventory. We have a daily huddle process. The daily huddle process is through the whole organization. Every day goes through all the tiers up to tier 6 CEO level, then it reports back. Immediate communication around the whole enterprise. 77,000 employees can do that across everybody. We do that in supply chain, we do that in food or SPD or anything. We then can do global reporting and tools. So if I create a tool that says, let's say on time and full measures, I can, if it's all on the same system and it's all in the same data set, I can say, show it to me by market, by geography, by site, by leader, and then I can just manage it wherever it is. We think of the supply chains as global. So the supply chain is just everywhere. And so when we act that way. Where do we have shortages? Where do we have challenges? Where do we need medical directors to provide feedback? They're global. We have the same integration playbook. So when we set up a site, we set up one in Middlebrook or Mentor. And as we set that up, it's set up the same way we set up our other part rooms. It's set up on the same system. So our inventory management, same system, same process. That's great for us. A caregiver can go from Florida to Cleveland to any site, it's going to be the same system and the same policies and the same way to do it. And the same with a nurse and the same with a physician. Anywhere they go, same thing. And that way it's repeatable wherever we are. That really brought maturity. So now, what makes that extra hard? Well, what about any differences in location if you're not close by? We use a distribution partner to make sure we can use their warehouses wherever we are. We don't have a concentration. I can't have a central distribution center to serve Nevada or just one operation in London. So we use distributor partners. You need local decisions like weather, right? Florida has a hurricane coming in. They need to be able to handle their own hurricane preparedness that, believe me, is different than Cleveland hurricane preparedness. It's not as much. We have a storm preparedness. So we have a stock program that handles hurricane preparedness in Florida. You have to have that kind of local deviation. And what about lead times? If you say, where do you have easy access to material? I have easy access to material in Ohio because I have such concentration and density. I don't have that in Abu Dhabi. And I'm relying on a vendor partner to be able to ship into the country. But if I can have commonality in service lines, if we're all using the same pacemaker, well, now that I can backstop demand and I can say, look, if you make extra for Abu Dhabi and it's the same SKU and we can use it globally, that's an if. But if we can, then I'll commit to use it in the US. I'll backstop it. Generally, that's not the problem. The problem is making sure you have the right demand plan and the right forecast. But once they know that it's the clinic and we're thinking globally, they're less worried about, okay, X pacemaker is going to be obsolete wherever we are, because you have to have that rational service lines. What care will be provided where? You're going to have centers of excellence, right? You're going to have places that are orthopedic sites, orthopedic experts, versus sites like Nevada are more focused on brain health. That's okay, right? It's not the same formulary in every place. You work with your nursing teams that say, this is the formulary, these are the surgeons. Okay. Our inventory systems are flexible enough to handle that sort of local deviations. I would say we learned the space question. Make sure you have the right amount of room for your storerooms, your par rooms, the receiving dock, all those things. And we're very closely partnered with our construction, buildings, and design team on here's our standards, because if you don't, then you can't have the right supplies, you can't have the right rooms, and again, you have local flexibility. So you get lots of challenges, but I think we're further than most. I think some of those folks who have really broad geographies, some of our peers who are covering 7-10 states, have it a lot harder.
Yeah, it's I always thought it was a daunting challenge though, because when you acquire a new, say Mercy Medical Center, I mean, I say that because I'm familiar with it. Were their operating systems the same as yours? You have to retool those on the fly. You have to the changes you have to make to become operational. You have to think that all out in advance before you start to flip any switches. It's a daunting task, I would think.
Bring the supply chain folks in on the diligence. It is always my advice. It has been my whole life. In the med device world, we were buying lots of companies a year. And I was in the very beginning. Supply chain should have a seat at that table. The planning you can do ahead of time of what your supply demands are, systems, how you're going to do traceability, who's your distribution partner, who provides your food, all that sort of infrastructure stuff. You'll know the culture and the systems and the work ahead of you if you're in the diligence. If I turn around on day one and hand it to you and say, hey, Fred, good luck, that's a lot harder than if you knew what you're getting into and you had the right experts and everything all aligned.
True. I know that you have you decided you've got an overarching supply chain perioperative plan that you're building. Could you tell us a little bit about that?
Sure. Yeah. It's an area that supply chain isn't always deep in. And I think it's the highest spend, and it's an area where supply chain can provide an incredible amount of value. So, all the way up into the OR storage areas and the procedural areas, cath labs, IR. Today, we already have part of that. We have the supplies up. We manage all the supplies up into those rooms. Everything is on WaveMark. We tag anything that's $50 or implanted. So I can already tell you where every unit is, everywhere they are in our system. Our teams are already there. We're already set up with point of use units in the ORs to be able to tell when a product gets used and how much, and provide serial number, lot number information already in the Epic. And we're already closely embedded with the OR teams because of that. So that's step one. Get into the OR, right? Take over that part. That took us a while. That was a journey. It was before my time, but there's a journey. That then you earn your trust, get yourself there. Now you're in the OR. Our end vision is, yes, supply of periop. We have our Accelerate contracts, so we even can say, the best PPI contracting, but all the periop items picked onto case cards. So we'll do the picking with accurate procedure cards. The important key there, procedure card, not preference card. Accurate procedure cards coming from a centralized PPI depot with a vendor that has visibility to the case and what we need from them for that case. Now that's a vision, right? So we have the supply to the OR and we have visibility to it. Great, good source. We're able to get the items. We have strong value analysis. We have the ability to get it there. What else did I mention that is part of our journey? Preference card cleanup and moving into procedure cards. So getting the preference cards all into our systems in the Epic and then cleaned into procedures. Pick a procedure, get the agreement on what the procedure card's going to be, and then get agreement. We just talked this out with the executives this morning. It makes sense because then everyone knows what they're going to use. It's an approved set. You will have variations. You'll have 3 variations. Physician variables, size of glove, robe, etc. What light handles you need in the OR or whatever it is, so site-based. And then anything clinically different. I may need a different implant or I need something special for this one. But otherwise, you can have a procedure card. There is your demand, right? Then you can now say, go pick the case card from that because I know what to go pick. It's not legend. It's not handwritten on a binder somewhere. It's not in somebody's memory. You can hand that over to me. In a lot of worlds, SPD's picking, in other ones, nursing's picking it. The best use of clinical time is not picking a case card. Let's let supply chain do that. And then why doesn't it come from a centralized depot? We have PPI all over the place. Why does Hillcrest have some and Mercy have some and everybody has their own people? Put it in a geographic center. That way you can do all the consignment in one place, centralized managing of it, and just bring a few days of inventory out to where they need it. And bring the vendors in with what your needs are. Show them the procedural forecasts 6 weeks out, as far out as you possibly can get visibility, and then show them what you need. If I need consignment for something, is it fair for me to say, hey, Fred, I need this tomorrow? Like, what are you doing to me? Like, why do I have to go run around and bring this tomorrow? That's crazy. Well, if I knew about it 6 weeks before. So the idea is as much vendor visibility as we can get. But again, you got to have everything right. If I don't have the inventory accurate and I don't have consignment in my WaveMark and I don't have preference cards and I don't have all that centralized, like what am I doing? So we're working on all of those pieces. It's about a 2-year journey. The technology, honestly, is not the hard part here. The technology of all of that is generally pretty available. The centralizing the PPI is a bit cultural, getting the procedure cards cleaned up just takes some time. So it's the first hard step is saying, I'm allowed in the OR. You can trust me to get this far. And then I think in the end, it's having that vision of how far can you take this?
Yeah, that's not an easy thing. A couple of things that you brought to mind when you were telling this. I think it was 1998, so it's a while ago. But Jim Francis was the supply chain leader down at BJC, and we did a big project there. VHA Performance Consulting did, and they had over 16,000 physician preference cards, and I was supposed to be helping them pull cases. And I was working with this guy named Al, and Al says, "Let's pull the cases." I said, "Don't you need to look at the preference cards?" Nah, I know what the doctors are using. He said, "Dr. Jones used 4 of these, 3 of those, 12 of those," and they were getting probably about 45 to 50% return every day of unused items. That. And the second part about not giving lead time because of not knowing demand, I think 90% of the supply chain folks loved it because they got to do their heroic intervention thing every day and save the day at the last moment. That's how they justified their existence. So you're basically you're dependent upon good process, building consensus, and good data to actually be able to forecast demand with a high degree of confidence. Is that fair to say?
That's a great way to summarize it. Yep.
And that's not accomplished overnight.
It's a journey.
OR people, this is an editorial statement from me, not you, have always loved to control their environment, and they have seldom trusted anyone outside of their doors. And so that's a pretty good challenge you're taking on.
Well, Fred, it goes to managing the risk. If you have a patient's life in your hand, something is not going to go well with this patient. It's my fault. And if it's my kid on that table, I want the least amount of risk possible. So how do you minimize that risk, right? If you can be assured that my supply chain partners have this nailed, they know exactly what I need. They know where it is better than I do. Their systems are super advanced, right? They've got the full warehouse. They've got the pick sheets. They're delivering exactly like I need. It's wrapped. It's ready. I know the person if I have a question, right? There's not risk there. But if you are half showing up or they don't like the people or you mess up half the time, then there's too much risk with this.
Right.
And the way they manage that is, okay, I will make sure this is not a problem, right?
Yep.
And it's not a malicious intent. It's managing safety for the patient. And I always think of it that if you think of the patient first, what do you have to do to keep them safe? Then it's put the best process in behind that, and it'll manage the risk.
Very good. I got 2 more questions, I think, here. Number 1, do you have common KPI across the system so that if you're looking at supply chain operational effectiveness, do you have the same standards that you're measuring everywhere, applying everywhere? And if so, just what are some of those?
We do, yes. So spent a lot of time building our metrics and our dashboards and making sure that's the right level of service. Things like where are we in financial aspects of savings, percent supply cost as a percent of net patient revenue, things on the financial front. We have operational metrics. We have one that I call facility health, but it's are my bins turning at the right speed? Am I getting stock out at individual bins? Are they slow moving or on back order? And are we processing recalls timely? We put all that together into a facility health score, and that helps us say the operational side of what's happening at the facility is functioning, and we can do that across the enterprise so that everybody sees it, so they can see who's doing well and who's not, so they can call each other and say, wow, how'd you get your score so high? Oh, here's how we do on time and full measures. That's with the supply community, so we can see performance and we can ask questions about, is it something on our side? Maybe we have unrealistic lead times, or maybe a supplier didn't ship something and we should be worried about it. We look at back orders and how often, where our back orders are they increasing or decreasing? We look at things like food scores for Press-Ganey results. So we have common measures, RNI and INR, all those sorts of operational measures. We have a data health one that tells us, because it's kind of the core of your supply chain, is your data clean? Is it filled out properly? You have all the right descriptions, all the right categorizations, right? You have any duplicates, whatever. And then transactions, are you transacting with a perfect order? Is it going electronically, touchless, payables? And so all of those lead in. Then we measure compliance, formulary compliance. So is everybody aligned to our commitments? If we say we're going to be 80% committed in the category, are we, or are there any sites with deviations for some reasons? We manage all of that in our systems with dashboards, so you can say, show me how we're performing in X category and show me how my peers are doing. I can do it sites, markets, countries, whatever level I need to.
Well, that's great. So your folks know where they stand in relationship to others, and you know where the entire overall operation stands in relationship to your stated goals. That's pretty good.
And I have goals in there, but we also have benchmarks of the industry. So industry folks help us with, okay, this is common practice for X. So we're like, we know we could be better than this. It can't just be your own view, because you don't know that you're necessarily being great.
Right, true. Another question: are you, like virtually everyone else in the country, having difficulty hiring and retaining staff, and not just staff but key staff? One of the things about an evolving, more sophisticated healthcare supply chain is we've gotten past the point where all we got to do is know how to back the trucks up to the dock and push boxes till it gets to a certain place. We need different skill sets now by far than we did 50 years ago when I started in the business. Are you having trouble finding, hiring, and retaining staff at all kinds of levels? And if so, what are you doing about it?
Well, Fred, we live in Cleveland. Everyone wants to be here, right?
Well, that's part of it, but those of us that know how really great Cleveland is don't want other people to find out.
The best kept secret, right? Now, I think we do really well on this front. The clinic, one of our pillars is caring for caregivers. And so we take care of our people and the organization, the patients, the community. But the people, we definitely do try to bring in the best, and then we try to keep the best and make sure they stay. So you don't want to bring them in and then have them leave. It's cultural. I'd say our team of teams culture is my favorite part of it. I've lived it since I've been here. And tell you a story, we had some of these shortages come up, and I talked to my peers in the market, and they're like, Steve, I'm getting yelled at. And I'm getting yelled at for running out of this stuff. They said I should have foreseen the shortage coming, even though nobody did. And it's just negative. And I'm like in shock, because when I had the shortage, I just got everybody on a call and said, okay, folks, we have a shortage. It's unfortunate. Here's what happened. And we go around and everybody says, here's what I'll do to help. And it's the mentality of, if a sick patient showed up, everybody would come to the bedside and not blame the patient for getting sick. Why are you here? It's, well, how are we going to treat the patient, right? And everybody says, I'll do X, Y, and Z. And it can be anywhere from operational people to finance people who are trying to get you resources to do stuff, to facilities folks, whoever. And everybody chimes in, and then supply chain can be the coordinator, but we're not the only one carrying this. That really helps, because you feel like, okay, this is a group effort, right? Everybody wants success here. Nobody's waiting for you to fail, and you want to be part of those teams. So we bring the folks in, they feel that environment. I think finding them is sometimes hard. We do internships, we do co-ops, we do a lot of community investment, community building, and kind of bring them in, get everybody trained. We try to leverage technology where we can promote like the best high value work, right? So if we can build an RPA bot to just key something and it's just not really value added work, then great. We have a citizen developer program where folks are building RPA bots, and you just submit it, we get a bot, and next thing you know, you've got a much better service. We use our AGVs or robots to move materials long distances, so you're not having to push carts all the way through the tunnels of main campus. So technology where you best can help, I think that's important as well. Some areas are harder than others. And yes, things like SPD or food or, places where you need real specialty knowledge, you got to be more creative. You got to have more like internship programs or certification programs or programs where the longer you stay, you get escalated with certification. So we work hard at all those, but I've found it to be a really great culture for doing that. I think the other thing, our culture, patients first, and it's always about patient care, and you feel that. The stories we tell in our meetings are about patient success, and everybody is drawn to this business because you want to help patients. And then we do innovation and education. So on the innovation front, we're not afraid to try new things. Like we have the first quantum computer. We're early in doing things. So we encourage folks who are out of the box thinkers to join us, and then they feel like I'm amongst peers who can do new things. And so we're not afraid to try that. And then we're not afraid to tell people, because we tried it, and then we can either share that it was horrible, guess what I learned, or this was a really great success, and let me tell somebody about it. So doing like a podcast with you, we're happy to do it. I can come back in a couple of years and tell you how our periop supply chain ended up, and I never got my procedure cards clean, Fred. This is what happened, right? But I don't mind sharing that because it's all part of innovating and educating and part of what we do.
Great. Well, now the toughest question that I've asked all day. Okay. I know you're not a Cleveland lifer, but you are a Clevelander now. So do you think the Cavs, the Guardians, or the Browns will make the postseason in 2024?
I live here, so I have to say yes.
You don't have to say that. We all live here too, and we know the difference.
Fred, I will tell you, my first observation is how humble Cleveland is. And as a city, you even said it before, we don't want anybody to know. And we're not out there on the headline saying Cleveland is incredible. And it's the same for the sports fans. The Cavs, the Guardians, and the Browns are like, we may not win, but we're awesome. And we'd really love it if you would be a fan. And I tell you what, they are so much fun because of that. We went to Browns games this year, and it was like, this is incredible to be a part of. To see Joe Flacco be so successful. And everybody was like, we don't know where this is going to end up. We hope he's still with us next year. This is great to be part of. Everybody enjoy the ride. And of course, you're going to be like, this is amazing. I'm happy to be part of it. I find that that's what the whole culture of Cleveland is like, and it's fun to be part of.
Yep, I couldn't agree with you more. I've never lived in a place that I love as much as where I'm living right now. So, well, Steve, one free throw, anything that you any point you want to make that you haven't made?
Ellie, thanks for doing this, Fred. I appreciate what you guys are trying to do for the ecosystem. And we are one ecosystem of supply chain. We're all in this together, right? It's all the patients. So I see what you are trying to do, and I'm happy to share knowledge. I'm happy if folks want to reach out to me. I like the fact that we're trying to improve each other. In the end, it's about the patients. I would say the more transparency that we can get in this ecosystem, the better. And that's things like common metrics, common terminology, all the way from early manufacturing to distribution to health systems to GPOs. The more transparent we can be and share with each other, the better. Have a common metric that says, not here's your delivery, but here's when items are going to arrive and delivered. And things that are just common across the spectrum. We don't do a good job of that as an industry. I saw it in the CPG world. They do it all the time. Things like Walmart telling a supplier what they have in stock on a shelf at the Chagrin store. So the supplier sees they're out and they're like, of course I'm not getting sales. I don't have product on the shelf. why can't I do that in my ORs to say, hey, Mr. Pacemaker, you're not getting usage because your product isn't here. And that sort of transparency, I want a commonality of doing it. And if you think about we're in this for the patient, then you would say, okay, all the rest of us act on their behalf to improve their care. We're changing a lot. There's a pace of change is accelerating like crazy. And every time you turn around, it's RPA and robots and AI and everything else. And the technology, even just in the providing of care, is changing so fast. So we all have to kind of stay on top of all that, change incredibly fast, be open to that change. And I think you do that best when you're open with each other about, here's what I learned. Here's some great thing that is working in another industry, or here's a risk management program that we thought that worked in banking that would be really applicable to what health systems do. Awesome. Let's learn all we can about it. I think all that's valuable.
Wow. Well, Steve, it has been a real pleasure spending time with you today. I appreciate your willingness to talk with us, your openness, and the level of depth that you are willing to go into about things. It's really great, and I hope sometime we can get together.
I would love that.
I really appreciate it. Thank you so much, everyone. Steve Downey of the Cleveland Clinic Foundation. After today, you understand why the clinic is as great as it is. Thanks, everybody, and we'll see everyone the next time. And Steve, hope to see you soon. Thank you.